Okay, so let's get down to business. And before we go on to the definition and the other aspects of heart failure, um, before we can discuss therapy, we have to understand what heart failure is. And so the first few slides are going to be on the background of heart failure. What is heart failure? How do you classify heart failure? How do you stage heart failure? So these are very important things to understand about heart failure. Okay, so when we say heart failure, what are we talking about? So it's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. So essentially, the heart is not doing its work. It's not pumping blood. The function of the heart is to pump blood out to give you what we call a cardiac output. So if the body is not getting a sufficient cardiac output, it will let you know. The body will let you know. Okay, so the body is accustomed to getting a certain amount of blood per minute, um, so that the different tissues and organs can function. They can manufacture energy, they can get rid of waste and stuff like that. So once the heart is not doing its job in terms of pumping blood, the tissues downstream and the organs will let you know. Um, all right. So, what are the clinical features of heart failure? So, if you have heart failure, you're going to have some aspect of shortness of breath. So, we call that dyspnea. You're going to have some aspect of shortness of breath. And if it's not something that occurs very acutely, your shortness of breath will occur with exertion. So, it might be, if you normally walk 6 blocks to go to work or whatever, the first thing you're going to recognize is that you can't do it anymore. You're going to be short of breath. Okay. Um, so that's the first thing that's going to occur, shortness of breath with exertion. When the heart failure gets really bad now, then you have shortness of breath doing your regular activities. You know, just going upstairs, you're going to be short of breath. Doing chores around the house, you're going to be short of breath. When it gets really, really bad, then you have shortness of breath at rest. Whenever you lie flat in bed, you get shortness of breath. You have to prop yourself up, so you probably use 2 or 3 pillows, and then you may graduate to the chair, the recliner, and then fatigue. So fatigue is also another very important feature of heart failure, and that is because the tissues are not getting sufficient blood, and they become fatigued. Limited exercise tolerance. If you normally could walk, say, 6 blocks in 2 minutes, now it may take you 10 minutes. So simple things like that, okay? So fluid retention is also a manifestation. But fluid retention, you may not see manifestation of fluid retention. So be careful of that, okay? Uh, Again, if the heart is not pumping out the blood, you can get some amount of congestion. But we used to call heart failure congestive heart failure, but we have recognized that some patients do not present with congestion. So we had to modify the definition somewhat. But fluid retention and the fluid retention can be anywhere, you know, because again, if the heart is not pumping out the blood can back up into the lungs. If the right side of the heart is affected, then you will have ascites, you can have hepatomegaly, the liver can become engorged and congested. One of the important, the most important feature of congestion or volume overload is the JVP. And people who are doing exams, they will ask you that, right? So if you want to look for volume overload, the JVP is the most uh, important clinical sign that tells you that there's congestion. So again, when we talk about pulmonary edema, it's chronic congestion. So the vessels going to the bowel, they get congested, and then the bowel also get congested, and the bowel doesn't work as it should. Someone who has acute decompensated heart failure, a lot of time they do not absorb the medicine you're giving them because of congestion of the bowel. Peripheral edema, not everybody is going to have peripheral edema. So yeah, you may see swelling of the legs or sacral swelling, but you can be in heart failure without edema. So, heart failure is a clinical syndrome. And when we say heart failure, again, the heart fails. The heart fails to perform its duty as a pump. And remember, the heart is made up of the pericardium. So it could be pericardium. You may have a constrictive pericarditis. You may have tamponade. You may have a myocarditis, or may have a myocardial infarction. So the myocardium, the muscle, may be involved. The endocardium could also be involved. The valves, the heart valves, could be causing the heart failure. The valvular stenosis, valvular regurgitation, or the great vessels. The pulmonary uh, artery or the aorta. Or you can have metabolic abnormalities, which gives rise to heart failure. So, when we say heart failure, it could be a number of things. And remember, it's a clinical syndrome, so you have to specify what's causing the heart failure. Now, we're going to come to some terms, some definitions, and it's not really new because we've been using this for probably close to 10 years. But when we talk about heart failure, we usually talk about heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. And it's simple, as the name suggests, you may have heart failure, so the signs and symptoms of heart failure. But when you look at the ejection fraction, it's less than or equal to 40%. That's what we call heart failure with reduced ejection fraction. So signs and symptoms of heart failure, you do your echo, ejection fraction is less than or equal to 40%. We used to call that systolic heart failure, but the proper term currently is heart failure with reduced ejection fraction. Then we have heart failure with preserved ejection fraction. So these are patients who have signs and symptoms of heart failure, but when you do your echo and you look at the ejection fraction, it's greater than or equal to 50%. Now, your heart failure with preserved ejection fraction is going to take a little bit more than just looking at the ejection fraction. We'll discuss this a little bit more in depth. And then you'll have another category, a borderline category, where the ejection fraction is 41 to 49%. So these could be some patients with heart failure with reduced ejection fraction who have improved, or they may be patients with heart failure with preserved ejection fraction who sort of deteriorate a little bit. I wouldn't get bogged down into this category, but the heart failure with reduced ejection fraction and the heart failure with preserved ejection fraction, those are the two categories that you need to know very well. Okay? All right. So how did we come up with this less than or equal to 40%? And that came about because most of the randomized controlled trials that we looked at, we usually use patients with ejection fraction less than 35% or 40%. And because a lot of the studies were done in these patients, we know how to manage these patients. We have a lot of data in these patients, and we sort of have a very good way of treating these patients. So, you know, I don't want to say that the ejection fraction of less than or equal to 40% was a random one, but because of the studies that were done, look at systolic patient with systolic heart failure with an ejection fraction less than or equal to 35%. So we continue to use the definition, okay, that definition. So if a patient if a patient comes and we suspect heart failure with reduced ejection fraction, so you'll hear they talk about FREF, okay, and FPEF. You know, I like to say heart failure with reduced ejection fraction, not gonna, you know. So again, um, so again, to make the diagnosis, you need an ejection fraction less than or equal to 40%. A lot of matter of fact, all patients with systolic dysfunction usually have diastolic dysfunction. And we have criteria to diagnose diastolic dysfunction. We have specific criteria for that. So it's not only heart failure, you know, when we say heart failure with preserved ejection fraction, if we're talking about diastolic dysfunction, we have specific criteria to make that assessment. So heart failure with preserved ejection fraction, again, the ejection fraction is usually greater than equal to 50%. And people who are doing the exam, they usually, you have to have the correct definition, because they're going to ask you the definition. You need to know the correct definition. So ejection fraction greater than equal to 50%. And when we look at all patients with heart failure with preserved ejection fraction accounts for about 50%. So half of your heart failure patient is going to have heart failure with preserved ejection fraction. Sometimes the diagnosis is a little challenging, but you know, you can make it. And you know, it's sometimes a diagnosis of exclusion. You know, the patient's going to have signs and symptoms of heart failure, and when you do your echo, they have evidence of preserved or normal EF. But the correct definition, ejection fraction greater than equal to 50%. All right. We can diagnose LV diastolic dysfunction, but that's a specific diagnosis, however. So when we talk about LV diastolic dysfunction, we can use Doppler echo or cardiac catheterization to make that assessment. So not because the ejection fraction is normal, you're going to say the patient have diastolic dysfunction. It's a specific definition for that. So if we look at the incidence of heart failure with preserved ejection fraction, those patients, that population of the heart failure patients is increasing. And we usually, you know, patients who have this heart failure with preserved ejection fraction tend to be older females, you know, somewhat on the thin side, and they usually have hypertension. Okay, so your older patient, older female, low weight and hypertensive. So those patients tend to have heart failure with preserved ejection fraction. Also, very common in this group, uh, patients who are obese, patients with coronary artery disease, diabetes mellitus, atrial fibrillation, and hyperlipidemia. So your heart failure preserved ejection fraction patients tend to have a lot of these comorbid conditions. All right, so now we're going to go into the classification of heart failure. Now, we are staging heart failure, and you need to, especially people doing the exam, you have to be very clear about the stages of heart failure. The stage of heart failure is different from the class of heart failure. When we talk about the stage of heart failure, we emphasizing the development and the progression of heart failure. And the first two stages, that stage A and B, these are asymptomatic patients. Okay? So your stage A and your stage B heart failure patients, they're asymptomatic. They don't have any symptoms whatsoever. Okay? Again, the stage also take into consideration risk factors and the abnormality of cardiac structure and associated that are associated with heart failure. So let's go on to define these stage. So again, stage A and B are asymptomatic patients, they have no symptoms. Stage A patients are patients with just risk factors that can lead to the development of heart failure. So stage A, patients have risk factors that can lead to heart failure. Stage B now, they have some type of structural heart problem, but they don't have any symptoms. Okay, so you must have seen patients with, they may have a valvular lesion, they may have, some mitral stenosis, or they may have mitral regurgitation, but they have not yet developed heart failure. So that would be your stage B. They have structural abnormality, but not yet heart failure. So A and B are asymptomatic, okay? And your stage C, sorry, your stage C is your symptomatic patient. So stage C patients are patients who either they have had heart failure symptoms before or they're currently having heart failure symptoms. Those are your stage C. And then your stage D patients are your real sick patients. These patients are refractory. These patients, they need some type of significant intervention. They may need, um, LV assist device. They may need intravenous inotropic medicines. They may need, so these are real sick patients who need significant intervention. So again, A and B asymptomatic. A, all they have is risk factors. B, these are patients who have structural heart disease. C, patients who, that those are the patients who you normally see, either in the office or you see them in the hospital. Regular heart failure, you treat them and they feel good. You go home, you keep them on their medicines, and you talk to them about diet and exercise and stuff like that. Those are your stage C. Stage D patients are your refractory patients who are very sick. Now, the stage is different from the class. When we talk about the class of heart failure, we talk about the New York Heart Association classification. So, New York Heart Association classification. We have stage 1 through 4. So, the higher the stage, the more symptomatic the patient is. So, the class focus on exercise capacity and the symptomatic status of the disease. So essentially, the class is telling you about the symptoms. So Your class 1 patient, minimal, they have essentially no symptoms, okay? Class 2 patient, they will have symptoms with minimal activity. Sorry, they will have symptoms with regular activity. And then your class 3 patients, symptoms with minimal activity. And then class 4, they're going to have symptoms at rest. Okay, so the greater the classification, the worse the patient, symptomatic wise, the patient is going to be. So the class tells you about the severity of symptoms. So you can see that there's a difference between the stage and the class. Again, people who are doing the exam need to know that and know that very well. So as we pointed out before, when we look at the stage of the heart failure, okay, so stage A, these are high risk for heart failure, but without structural heart disease or symptoms. So they have no structural heart disease and they have no symptoms, but they have risk factors. And we're going to look at the risk factors that lead to the development of heart failure, okay? Then your stage B patients have structural heart disease, but without signs and symptoms of heart failure, okay? So because your stage A patients have no structural disease, you cannot give them a New York Heart Association class. So your stage B patient, however, they can be they can have a class 1. Okay, so no, your class 1 is no limitation of physical activity. Ordinary physical activity does not result in symptoms, so they're not symptomatic with ordinary physical activity. All right. So your stage C patients, as we pointed out, they have the structural heart disease and they had prior or current symptoms of heart failure. So these are the regular heart failure patients. They have had heart failure symptoms before, or they currently having heart failure symptoms. And they can be in any New York Heart Association classification. Then they can be class 2, slight limitation of physical activity. They comfortable at rest, but ordinary physical activity results in symptoms. Okay? And then they can also be class 3 with marked limitation of physical activity. They're comfortable at rest, but less than ordinary activity causes symptoms. So, you know, they're going to be symptomatic by just doing their regular activity. And then your class 4, they're going to be symptomatic at rest. Okay? So this is the stage C. They can be class 2, 3, or 4. Remember, the class tells you about the symptoms, okay? And the stage tells you about the progression of the disease. And then your stage D patients, they are refractory heart failure patients requiring specialized intervention. You might have to give them intravenous medicines, dobutamine, dopamine, whatever. You probably need to give them those medicines. They may need LV assist device. They may need, we have other things, Impala. You might need to do ECMO, but they need more than just regular uh, therapy. So let's look at the epidemiology of heart failure. So the lifetime risk of developing a heart failure is about 20% for Americans over age 40. So, which is pretty high. Okay. So, if you're over age 40, about 1/5 of the population, that population, uh, can develop or will develop heart failure. Annually, there's about 650,000 new heart failure cases diagnosed. And then if you look at the whole population of heart failure patients in the United States, about 5.1 million, individuals. It increases with age. If you look at age 65 to 69, it's about 20 per 1,000. And greater than age 85, it's about 80 per 1,000. So it's a disease that uh, increases as one age. And as we had pointed out before, the half of your patients is going to have heart failure with reduced ejection fraction, and the other half is going to have heart failure with preserved ejection fraction. So they're roughly about equal. But you know the older, when you look at the older population, heart failure with preserved ejection fraction is going to increase in percentage. And blacks have a higher risk of heart failure. All right. Over the years, the mortality from heart failure has decreased, and so we have better medications. We have medications that improve survival. Things like education, cardiac rehab, and we also have device that impacts mortality as well. Defibrillators, resynchronized therapy, which we spoke about recently. So the mortality is improving. However, without any intervention, 50% of patients with heart failure uh, uh, will be dead in 5 years after diagnosis. So if nothing is done, you just look at the natural history, about the death rate is about 50% in 5 years. When you look at the ARIC study, which is the atherosclerosis risk in communities, the 30-day case fatality rate is about 0.4%. The 30-day case fatality rate is about 0.4%. And the 1-year case fatality rate, 22%. 5-year case fatality rate, 42.3%. So this is a relatively recent study. Now, if you're going to look at mortality for the different stage of heart failure, so again, remember your stage A patients are asymptomatic. All they have is risk factors. If you have stage A heart failure, you have 97% survival, 5 years. Stage B, 96, because you have structural heart disease, but you're relatively asymptomatic. Stage C, though, 75% survival, 5 years. And again, we have much better therapy than we had, say, 10 years ago. So these patients do very well. The patients that we still having a little issue with is the stage D patient, because there's only 20% survival. So these are your refractory patients. And we'll have a special session to go to look at these patients. The 30-day post-admission mortality rate decreased from 1993 to 2005 from 12.6 to 10.8. So, the therapy does work. The therapy does work, and not only in terms of reducing mortality, but reducing hospitalization and reducing symptoms. If we're looking at hospitalization, heart failure is the primary diagnosis in over 1 million patients annually. So it's a big number. A lot of patients who go to the hospital because of heart failure. The problem, though, the 1-month readmission rate. So you go to the hospital for heart failure, you get treated, but you have to be readmitted. So the readmission rate is about 25%. So 1/4 of the patients is going to come back in a month. The total costs annually in the US exceeds $30 billion. And half of that is spent on hospitalized patients. Treating patients in the physician office is only about $1.8 billion in 2030. So if we look at health-related quality of life and function, because the patient have to have some degree of quality of life, because when you treat patients, one aspect of the treatment is how they're feeling, so quality of life is important. Heart failure significantly decrease health-related quality of life. Patients going to tell you they feel sick. They're fatigue or some aspect of not feeling well. So heart failure significantly decrease that. Physical functioning. So they're going to tell you that they if they walk, they get fatigued, they don't want to walk, increased vitality. Females tend to have poorer health-related quality of life than men, however. And a lack of improvement in health-related quality of life after you discharge a patient from the hospital, if they tell you that they don't feel well, that's a predictor for re-hospitalization and mortality. Because if the patient tells you that they're not feeling well, they're not feeling good prior to discharge, then there must be something going on that you need to address. So other determinants of poor health-related quality of life, and these things are important. It's not the more glamorous portion of medicine, but it affects rehospitalization. It affects the patient coming back. So you have to address it. Things like depression, memory problems, you have to sit down and help the patient work through these issues. Depression, memory problems. Younger patients tend to have more problems, however. Higher body mass index, it's like very obese patients. So, and lower the blood pressure. Patient with sleep apnea also tend to have issues. So some things that will impact positively the health-related quality of life. If the patient is on ACE inhibitors or ARBs, angiotensin receptor blockers, that can modestly or delay the progression of the health-related quality of life issues. Cardiac resynchronization therapy. So we spoke about that last week. So if the patient is a candidate for resynchronization therapy, that definitely improves health-related quality of life. So educating the patient and certain disease management approach also improve quality of life. Self-care and exercise. So again, we have these sessions where you educate the patient about their disease. You sort of instruct them how to take care of themselves, daily weight, dietary stuff, and exercise. So those things definitely impact health-related quality of life, and it should be incorporated in your heart failure management strategy. So 7% of all of your cardiovascular deaths are due to heart failure. And if you look at the mean costs per patient is about, when you add these patients, it's about $23,000 just for one admission. So remember we said that your stage A patients, all they have is risk factors for the development of heart failure. They don't have any structural problem. So when we talk about the risk factors for the development of heart failure, we're talking about hypertension, diabetes mellitus, metabolic syndrome, or atherosclerotic disease. So these are the risk factors that, if they're not properly managed or modified, can lead to heart failure. So, so again, many of the conditions or comorbidities are associated with an increased propensity for structural heart disease. So again, if nothing is done, then these conditions can give rise to structural heart disease. So it's expedient to identify these risk factors and treat them to prevent heart failure from developing. So hypertension, we did a current guideline on hypertension. So, again, it has a substantially greater risk for developing heart failure than that normotensive patients. So once you have hypertension, you have a greater chance of developing heart failure. So you should aggressively treat the blood pressure. So heart failure is greater with the higher levels of blood pressures with older patients, and the longer you have the hypertension. So the take-home message: treat the hypertension aggressively. So long-term treatment of both systolic and diastolic hypertension reduces the risk of developing heart failure by about 50%. Treat the hypertension, and strategies to control hypertension are a vital part of public health effort to prevent heart failure. Treat the hypertension. Diabetes. Um, so diabetes is also one of the risk factors for development of heart failure. Obesity and insulin resistance are important risk factors for development of heart failure. And clinical diabetes markedly increases the likelihood of developing heart failure in patients without structural heart disease. So again, aggressively treat the diabetes to reduce heart failure. What about the metabolic syndrome? So the metabolic syndrome is a condition where the patient may have abdominal adiposity. That is, they have they are fat around the waist, around the hip region or the waist. So that's abdominal adiposity. They have high triglyceride levels, hypertriglyceridemia, low HDL. So you check the lipids, low HDL. They're hypertensive and they have fasting hyperglycemia. To have the metabolic syndrome, all you need is just 3 of these. So you don't have to have all 5, okay? Just 3 of these conditions will put you in the category of metabolic syndrome. And one of the thinking is that these patients have insulin resistance. So they tend to have insulin resistance. So again, only 3 of these five criteria. So abdominal adiposity, hypertriglyceridemia, low HDL, this is low high density lipoprotein, hypertension, and fasting hypertriglyceridemia. Okay, so other risk factors, so the atherosclerotic disease that we're talking about is, so if you have coronary artery disease, everybody know that you have great chance of developing heart failure. So, if you have blockage of the blood vessel around the heart, you have a great chance of developing heart failure. If you have a stroke, you have a great chance of developing heart failure as well. Peripheral artery disease, if you have blockage of the blood vessels in the leg, you also have a great chance of developing heart failure. So these are the risk factors that can and will lead to heart failure. So remember, your stage A patient, all they have is risk factors: hypertension, diabetes, metabolic syndrome, or atherosclerotic disease. They haven't had any structural heart diseases yet. So if they have structural, say a valvular leak or stenosis, coronary artery disease, that is your stage B. So once you have structural heart disease, that's stage B. Stage A and stage B are asymptomatic patients. They are asymptomatic. All right. So we're gonna stop here because I don't want to give the lecture for more than about uh, 30, 40 minutes because I think we lose our concentration after that time. So again, this is the first part of it's about 6 mini lectures